Welcome to our podcast on health and healthcare risks, along with a proposed model applied to a central USA MSA. Any mention of risk in healthcare circles drives straight to a very simple taking capitation. That's taking risk. Now, risk is so much better than capitating a healthcare system. All six stakeholders face huge risk across life, living, social determinants, and we all face those risks as we work with the organizations that bring health and healthcare to our communities. So, our risk discussion is going to broadly overview the risk by stakeholder, set a population health context using real population health as the measure, and then applying that to a Mid American MSA. I think it's going to be constructive. Thanks for joining us. I've assigned myself a basically impossible task, and that is to go through the risks of all six stakeholders. It was crazy to have tried it, but I'm going to stay with it. What we'll do is you'll see big amounts of words. I'm going to just hit the very, very highlights, and we're going to dash through here. Individuals, in my opinion, have more risk than anybody else because it's our own health. It's whether we're breathing or not, or whether we're eating right, whatever we're doing with our lives. We got the risk. So when it's not working, we go to the emergency room. We want the very best. We want it now, and we don't care about the cost as long as we don't have to pay for any of it. Employers, you know that ACA puts you in the health insurance business, and it's just purchasing in the most complicated of ways. There aren't very many insurance companies want to work well with you, and you know that cost shifting is still going on among the health systems and so forth. But employers could lead us through some really creative things. We've done creative things with employers for the last 30 years and made it work over and over. So jump on board and see what you can do. Federal government, massive. You've got constituents in every part of the country and a huge deferred liability, and managing something in a local community that's national is such a chore. And getting the insurance companies with the advantage plans, we didn't really transfer the liability there. State and local governments are absolutely fascinating. I've enjoyed it. States do everything from being a big employer to running universities and university medical centers and local health care systems and health districts, on and on and on. You're positioned to do really dramatic leadership things and coordinate it through the governments up through the state, local, and federal governments. Health systems, some of the most fun things I've done in my whole life is working with health systems to go direct to their members and go to their markets. Works really, really well. Not many health systems want to do it, and it gets all confused with whether they take risk and all those kinds of things, but actually going direct to your market is a good idea. And health insurers and health plans, sitting in the catbird seat, we'll see where that goes because they own the membership and the data and the customer service, so forth. So here we are. We're all in this thing together. It's pretty wild. So good luck with that. So remember, this is a discussion of risk. And remember also that we talked about the risk of all six stakeholders. It all coalesces into this one slide, which surprised me and I think actually makes perfect sense. We've distilled down that real population health is a process of better healthcare results, but it's really the individual that has a personal health nurse that they know and work with, and that primary care that they also know and work with. And that positions that team to then be able to examine medical centers of excellence for the kinds of conditions that need to be uh, covered and treated. And it gives them the smooth transition up into the episode and back home after the episode, and really important when it comes to end of life. So how does that apply to the population? I chose to use Omaha, Nebraska as an MSA, which has a little over 700,000 people in it. And the core is, as you would expect, but it's near $9.9 billion of annual spend in healthcare on 600,000 people. 9 cities in that next, I need to help do this, 9 cities in the next 20 miles, and then 6 cities. But the thing that you'll notice is that the spend and the populations have interesting shapes. What happens is that healthcare in every one of those places, completely different in what they need, but all of them could use the model that's on the right. And if we approach all the communities with that concept in place, it gives us a whole different ballgame. The point of all this, we have real risks, we have MSEs, healthcare is a major local economy, and many people want to complete their life at home, and yet the stories go where they don't get to, they be treated through their end of life, which is extremely expensive, which ties back to every one of these risk conversations. We started with risk, we expanded rapidly past capitation of healthcare. The visual really illustrates real population health, not a product or a program, but consumer-friendly reality. The progression logically integrates real population health into MSAs, and all of the 6 stakeholders can implement it. And it's really um, capital, it's very small capital and very small fixed costs, which is the problem with healthcare systems themselves. I have been fascinated studying this, and I hope that people get involved with it and start driving the conversation forward, because it is really needed, because this whole thing started because of this outcry of dissatisfaction with our healthcare system, not local, but the healthcare system in the U.S. There's a way to flip this on its ear and make really good things happen. It can be driven by any of the stakeholders. We're happy to help.